Good morning. Good morning. It's time to start our CareCast, brought to you by the Knowledge and Evaluation Research Unit. I'm Victor Montori and transmitting from Mayo Clinic. And today we have a outstanding episode, thanks to the generosity of the always brilliant Dr. Doreen Ravi. So Dr. Ravi is professor of medicine and head of the endocrinology and metabolism division at the University of Calgary. She's an academic endocrinologist, a health services researcher, and an ardent advocate for inclusive medicine. As a leader of the Canadian Clinical Practice Guidelines, Dr. Ravi is focused on improving person-centered care and the practice of shared decision making through the development of situational literacy. But I have to say that Dr. Ravi is also a ardent advocate, not only for patients, but for the inclusion, equity, and diversity in medicine and in healthcare. Doreen, welcome to the CareCast.
Oh, thank you. Welcome. Well, thank you so much for welcoming me, and it's going to be a pleasure.
Absolutely. And so, Doreen, we always start our conversations here by asking you, how does one become Doreen Ravi?
So, yeah, I think like many people, I've had it's been a journey, and having watched the CareCast before, I know you always like to talk about how much of it was sort of purposeful and strategic, and how much of it was serendipitous. And I think in my case, it was largely serendipitous, and mostly I have been very, very fortunate, very, very lucky, but I've also I've had a few less lucky moments. But I think when I reflect on what were the most formative experiences in terms of bringing me to this point in my life, I think the first experience was certainly being a patient myself. And so when I was 15, I was diagnosed with anorexia, and at the time it was a very severe case, and I was about 5'6" at the time, and I weighed about 75 pounds. So I was very emaciated. I looked very ill. I required a lot of care. I was in and out of hospital for my sophomore and junior years of high school. I was in and out of care, but I was often hospitalized for months at a time. And that experience was in lots of ways extraordinarily hard. I mean, I think it's a mental illness is something that's very isolating. It's very painful, not only to the person who's experiencing it, but to their families. Because I looked very ill, I had the experience of sometimes being met with like significant compassion, where people would be like, "Oh my goodness," like, they'd be worried I had some sort of terrible consumptive illness, and and then there'd sort of be a flip when they realized I was actually mentally ill, and then they'd be like, "Oh my God, what's wrong with her?" So having that sort of and then my parents also experiencing that, like sometimes these moments of like grave concern and these other moments of judgment, and so I think sort of having that experience of feeling very different, feeling a bit marginalized, I that sits with me to this day. I was also extremely fortunate to have a wonderful care team, and as I think about the experience now, I was also receiving care at a time before evidence-based medicine was really a thing. So I had this care team that wasn't constrained necessarily by some of the clinical guidance that they might have now. And I was very fortunate that my care team really was just very committed to working with me and being patient and trying to navigate through things together, and particularly my pediatric team. And so it was, in retrospect, one of my first very positive experiences with to some extent, shared decision making.
Mm.
In a time before it was really formalized. I just had this very loving team that, um, especially my nurses, that went out of their way to just really see the person in me, and welcomed me into spaces that I don't think many patients often get to see. I remember very fondly, not being able to sleep at night, and the nurses letting me sit around the nursing station with them and having a cup of tea and just chatting, and just feeling very, very welcome and very normal, and very connected. And I think that was a very powerful thing in terms of my healing. Um,
So it's interesting that as you start to tell us about your trajectory of becoming you, the first experiences of course, this challenge of being a patient, and a chronically ill patient, and a chronically ill patient with a mental illness. But also, one of these formative experiences is to encounter a caring team
mhm.
that finds way of bringing you in. So these are of substantial formative experiences.
Oh, incredibly. And then I think that because it was so long, of course, I had a variety of experiences. I think the first ones were very, very, were incredibly compassionate. But then as I aged out of pediatric care and went into adult care, it was a very different paradigm.
Huh.
And it was also very interesting in terms of, I think I mentioned this to you before, that at times it felt very, like I almost was on an anthropological study, that I was like sort of, like, especially as a adolescent patient on a general medical unit for like literally 2 months. Um, uh, I saw a lot of stuff, a lot of medicine, a lot of, um, I just had a lot of exposure to how things operate in, the medical industrial complex. And so that was also, a very, very informative experience. And I think the other thing that it gave me, an early education on, was social determinants.
Hmm.
And so, especially on a general medical unit, when I was there for as long as I was, a number of roommates, number of roommates that had a variety of complex chronic conditions. And really remarkable that, some of the things that stand out is, sort of the social status and social situations of younger patients that were there with complex disease relative to patients that, presented more older with similar conditions. And so, yeah, so it was a remarkable time for me, for sure. And I think that,
So hold on. So you could see this social extraction showing up in some sort of. Did I get it right? Did you perceive like a hierarchy within the hospitalized patients, that
oh,
some really serve in
absolutely.
another?
Oh, absolutely. Like, I think, it's and even for myself, like even on the pediatric unit, I adored my care team, but, um, you know, I roomed with a couple of other teenagers that had mental health challenges, then came from slightly different backgrounds. Um, and as much as I love my team, to say that maybe we were treated the same, I'm not sure we were.
Hmm.
Um, I think,
When we're talking about Canada here, right? I mean, south of the
yeah,
border, of the
yeah.
Canadian border, we see Canada as a more equal country, perhaps, than the United States. But you were able to perceive this in that microcosm of your hospitalization.
Yeah, it was. And I think that there was, and that's, and again, I think that perhaps what I perceived is a little less patience with, um, families that came from a different background than I did.
Hmm.
I think that I have the knowledge now that sometimes that frustration may not have been directed at the patient, may have been directed at the situation, may have been directed at the family, may have been directed at sort of just sort of um, you know, a, my care team, or the care providers on the floor, may have just, felt that a lot of their efforts or a lot of their intervention was sort of futile because, like, of the lack of winning conditions on the patient side. I don't know, but I definitely could see that there was, um, yeah, that there was a differential,
Mhm.
application of compassion and understanding at times, or at least that was my perception then. But the other thing that was quite clear is that at the time was that just that the severity of some of these chronic conditions certainly seemed to run across, at the time, like even at that time, I could sort of see that they cut across socioeconomic lines.
Hmm. Yeah, I would have thought that that periods of time where one is sick, one becomes self-absorbed, but the prolonged stay allowed you to probably get out of your own situation and look around, and you probably had already the wherewithal to begin to analyze what's going on, right?
What I think the nature of my illness was that I didn't think I was so sick, right? And that I was pretty, like, I thought I was fine. So I think that while there were a number of traumas that led me to behave in that way and led, me to, to perpetually hurt myself, in terms of just, not providing myself with the sustenance that I needed. Um, I was also, I think a big part of my identity was a learner. I was a good student, and that's how I was known. And so I think that there was this part of me that just felt it was my obligation. I'm in this new environment and I need to absorb it. And I wanted to go into medicine. I knew at that time I wanted to be a
you knew it
physician.
already.
I already knew it. And I think that, so I think that I don't think I was conscious about the fact that this was a, potential, learning opportunity. But as it turns out, that's how I did observe I did observe a lot, and I did take away a ton from that experience beyond just what I needed to get myself on a path to wellness.
Do you remember when you chose to go into medicine?
Yeah, actually, I was younger. I was actually 10. And there was a
Oh,
couple of things. Yeah, 10.
I
Yeah,
mean,
and
this
there
is
was
when
a
I'm thinking I'm going to be an astronaut or a, fire, is that?
yeah. No, I'll tell you. Like it's a yeah. I mean, it's because there's some insights into probably like um sort of the how my brain works. But so as a little one, like my mom went back to work when I was in grade 2. And I thought that was the most amazing thing. Like I was just so proud of her. Like she'd gone back to school and she had trained and she went back into work. And I was just like, I think I was like a cheerleader for my mom in a way that I think she found rather annoying, because she's just like, it's not that big of a deal. But I was like telling everybody at school, and I just thought it was amazing that she was a working mom. And I think at the time I remember being asked, like, what do you want to do when you grow up? And I had all of these, I really thought that the choice of career opportunities was very limited. And I gave very traditional gendered kind of professions as my response to those questions. And then um, I had a neighbor that was a nurse, and I just thought she was like, I was really fascinated by her work, and I always wanted to talk to her about her work. And I said, I think I want to be a nurse. And she's like, I'll tell you, Doreen, like, I think you'd be happier being a physician. And then I was like, okay. And that was just, it was interesting that, I never even thought of that until she had sort of suggested it. And then just sort of on the heels of that, the other experience I had was one of my best friend's mother was diagnosed with breast cancer.
Mm.
And then sort of watching what that did to her family was something that was incredibly impactful, and to the point that I actually did a grade 5 project on cancer. So that also speaks to like the kind of kid I was. I was pretty serious.
Yeah.
Yeah, so
Yeah.
I was pretty focused.
So
Yeah.
then you became a physician, and then you became nationally active on guidelines. And
Yeah.
how does that happen?
So, well, I think that was again just luck. I think and this I've just been very, very fortunate to connect with some really incredible people that have just been kind enough to give me opportunities. And so the guidelines work really came out of there was a colleague of mine, Nadia Khan, who is a wonderful mentor, and she's a general internist in British Columbia, and she was she actually just stepped down as president of Hypertension Canada, where she was the chair at the time when she invited me on to the guideline panel as a reviewer. And so that was in 2010. And so, yeah, it was just one of those things that I was just, I guess I was always quite good in data synthesis methods, and so it was a natural fit. And I really liked I really liked the community. Got lots of academic opportunities in terms of writing. Got lots of networking opportunities. It was just a really lovely, professional experience. And then I was asked to chair the methods review committee and then chair the guidelines committee. And I became chair of the guidelines committee in 2016.
Mm.
And so yeah, that was just and I'll just say for any of the medical learners out there, I went into the guidelines at a stage in my career, in my mid-career, early mid-career, which is often a very difficult time. When you come on staff as an as a young academic, you're sort of seeing this person with all this promise, you're starting to get awards, and people are celebrating you, and you're like, oh, you're a rising star. And then I think it's quite common, I think, for women in particular, when they sort of transition to mid-career, that you start to feel like you were a person that had promise.
Oh,
And that can be a very crushing um, time, I think. And because, you sort of, and you start to have this anxiety about what am I going to do next? And it's a bit of a, like, I think academia does this weird thing to one's mind in terms of um, really nurturing a lot of self-doubt. And I think because of how the hierarchies and the meritocracy of medicine work, there are people that do get consistently left out and do get consistently left behind, and through not through any reason related to the quality of their work, but purely related to who they are and how our institutes are structured. And so the guidelines was a wonderful experience for me because it was something outside my institution. It was very, like, I was being validated in this other environment, which was, I think, for me, something that buoyed me and kept me going at a time when I think that my home institution was making me wonder about,
yeah.
sort of my value and my future a little bit. And I have to be like, I'm very, very grateful for my environment here at the University of Calgary. But I think that with the way our world works, and with our annual reporting, and with the pressure to produce, there's an ambient culture of what have you done for me lately that can get a little hard, I think, on the spirit at times. So that was a wonderful experience that way. But I think where the guidelines, it's interesting where it's brought me now is that reflecting back on my experience as a patient, in a time where, it was in 87, it was sort of before, you know, evidence-based medicine had really become a thing, before guidelines were really there. Um, and I wonder at times if, again, if there had been that structure around, what my care team thought should happen, and what they were being told, well, this is, if you're a good physician, this is what you'll do, how that may have changed the experience. And
So, so,
and
so,
I sometimes wonder if I sometimes think it would be less caring if that had
well,
been
yeah,
the
it's the
case.
second time you imply that in this conversation that there's an association that you're making between evidence-based practice and rigidity or less caring approaches. Am I getting that right?
Yeah, and I think it's at times, having been in the guideline space for so long, and I'm still in the guideline space, but it's an interesting space to be in right now, because I think we're all realize that we've got to shift a little bit. And I think that sort of the shared decision making discussions have gained enough momentum and enough visibility now that we really need to realize we have to make guidelines, work in a slightly different way, and we need to translate them in a different way. Um, but I do think for some time, that although it was never conceived to be this, and I think David Sackett never intended for evidence and clinical guidance tools to dictate or overly prescribe care. And he had even written an editorial in the BMJ in, I think, 1995 about care should be evidence based, not evidence burdened. And I think that particularly recently, when you look at sort of how much clinical guidance is out there, I think we may have tipped over into that evidence burdened zone where I think physicians, clinicians, feel very bound to evidence. Our quality indicators are very bound to evidence. And
Mm.
so the frameworks we have to give feedback on, is your care effective? Is your care high quality? All tied to evidence, and don't tie enough to the patient experience or the caring experience. So I worry at times that that this tool that was intended to create a unified standard of care and ensure equity in its own way, ensure equity in terms of the care experience, actually may have went sideways a little bit and created more distance between clinicians and patients, and yeah. So,
I
and
suspect
that's
that this
where I kind of sit now.
self-doubt that you were talking about, that academia and medical training offers to people, and then is selecting in some ways to people who then get trained to please and not disappoint, and not be found out, that perhaps they're not, as they don't belong, that they're this imposter syndrome, just flourishes in
Mhm.
that space. And then you have a guideline that that comes around and says, if you practice this way, you can sneak by, you may not be found, right? And then
Exactly.
people might actually find it to be a good crutch and a good way of feeling like you're competent, simply because if nothing else, the other signs that you're doing well might not be as strong in an environment in which you don't have much continuity with patients or much time with them to realize whether you're actually doing any good to them in the long run, because there is no long run. Particularly, I mean, you and I have specialty practices, and sometimes, continuity of care and longitudinal relationships are hard to come by.
Hmm.
I mean, I tease the cardiologists. I tell them that they don't practice evidence-based medicine. They're suffering from evidence tyranny, because
Yes.
any trial comes out, A is better than B, then everybody has to give A. Right?
Yes.
So how do you go from there to now? I mean, anybody that's been following on social media will see that you've come to be an international leader in equity, diversity, and inclusion. How has that transition taken place? Or maybe there's no transition; it's always been there, but it's just become known as part of your persona more recently.
Yeah. I think equity has always been a principle that's driven what I do and who I am. Like, I think even as I started my practice, and some of this relates to, again, sort of my own experience as a patient, um, that I had this awareness that like there's just like the you have to really examine the clinician patient relationship carefully to avoid it becoming inequitable. It's stacked to be an inequitable relationship. And there was things that just bothered me in terms of, I'd be, we advise patients to, to do a lot of work to look after themselves with diabetes. And I think that when I started my practice, I had very little children, and I remember once, talking to another young mom who was a pumper, and sort of saying, I think we have to do some basal checks, and this was back before CGM, and so that just meant she couldn't eat, and she'd have to test her blood sugars hourly. And I just remember saying, if I were in her position with little kids, and then someone told me you have to do some basal checks, I would just cry. And I think it was that I remember that conversation in particular just being something that just made me just really think about what it is that I'm asking of patients on a regular basis, um, and then sort of looking at how we construct medicine, right? And that you know that there's this crazy unfairness of sort of saying that you know patients come in for assessment and for advice and for guidance and for care, and they often leave with homework. And then if they have any challenges with their homework, there's very limited channels through which they can access you. They can only access you during certain hours. They can only call one number, and often there's this assumption that they have to call you by your title, but you can call them by their name. And there's all these things that just kind of make clinicians often unapproachable. And so early on, I just wasn't uncomfortable with that. So I've always been patients I've always wanted them to call me by my first name. I've always wanted, like, I've always given my email. I've always given my cell. Like, it's just like, if, you shouldn't be riding this alone. If you're having challenges, like, give me a ring, and, we'll work it out together. And interestingly, people often, are kind of surprised that I do that, and then are often very tentative about using those resources. But I just think on principle, I should make them available. And then I also feel it's really unfair that I get to ask them all sorts of personal questions and they don't get to know anything about me. So I think people over the years, I've always been very open. If people want to ask me about my life, like, they should and they can. And I don't think that like that my practice or my care is worse off for that. Like, I think it's actually, I think it's better for that. I'd say better for, I have to say, it's in terms of my own professional experience, it's gratifying, and very, very fulfilling, when patients come and ask about my kids, or, remember when my birthday was, or it's just,
It's
I'm very
amazing.
touched. Yeah,
Yeah.
I'm very, so it's just, I think care is just so much better. And as you say, we have the good fortune of these longitudinal relationships. I get to meet people when they're teenagers, and I get to see them have their children, and I get to see them, through their lives, and through the good and the bad. And it's such a gift to be able to
It,
ride shotgun in people's lives like that. So, but that's where the equity came in, I think, is mostly that I just feel that um, there's so much about people that we interact with that we don't take the time to understand or learn about. Um, and there's these hidden aspects of people's lives that when we take the time to, kind of ask and learn, it can, you know, it, it can take you in very, very unexpected, but also extraordinarily rewarding directions.
mhm. So equity as a guiding value of your career, in our unit we have three principles that we go by. Patient centeredness, integrity, and generosity. Any of these ring particularly strongly with you?
Yeah, generosity, for sure, for sure. And I think I've been very fortunate to have many generous mentors through my, you know, through my career. Um, I mentioned Nadia Khan, and my co-chair at the guidelines, Stella Daskalupolo. She's just a lovely, lovely person who's extraordinarily generous with, with her time and her knowledge. My partner, Bill, is a big model of generous leadership. The interactions that we've had, I've, always struck by, by people, and again, Bill's a great example of this, who's just, um, yeah, just he's someone that goes out there and is, he's an extrovert to begin with, but just, there's never puts a limit on time, never puts a limit on what he's willing to give to and elevate another person, and boost another person. And so I've benefited from that kind of mentorship. And I try to sort of take that approach, and sort of um, just pass the love forward, so to speak.
Oh, it's pretty evident to anybody that has interacted with you that generosity is like, in a Star Wars type of way, will be this generosity strong in you,
Yeah.
like the Force. What's been your favorite collaboration?
Oh, I think, yeah, I've had, again, very fortunate to have many. I think, I mean, my kids are a huge part of my life, and the best part of my life. And um, I think my family has been a lifelong collaboration, and I've learned so much from my parents and my brothers. And but my children are, like, I mean, I'm obviously biased, but I think they're amazing young people. And I think I've um, it's this anthropologist in me. I think sometimes I took sort of a bit of an anthropologic approach to my kids as well, and just, always, like, just always wanted to observe them and just sort of really understand the people that they were, and try to create environments, that were personal to them, that allowed them to succeed. And I think that I've always, like, my and probably, people often sort of say, like everything, democracy is great, but families, it's not so, it's not necessarily so much of a democracy, and parents get to have some authority. I'm not sure that my house runs that way. My kids have a fair bit of like, they have a fair bit of direction, and a fair bit of authority over me at times. But I quite like that. I think I've learned a lot from my kids. I'm amazed at how equity minded they naturally are. I'm also struck by and really sort of very, very heartened by how politically active they are. And I they like, as all teenagers, they're really good at keeping their parents humble. And I think that they've been pretty vocal about the things that they feel that their grandparents' generation, that our generation um, didn't do terribly well. um, and um, and I see this in my students as well, that um, you know I think youth often get dismissed as being unwise, or being um, a bit too sentimental. And the truth is that passion and that heart are such lovely, lovely things. And I think the students I've worked with in particular are remarkable organizers. And their voices are incredibly powerful, but they're not often heard. And I think this is another thing that sort of pushed me to where I am now, is some frustration that these young voices that are brilliant and and hopeful, but also pained at times, don't get the don't get the attention that they should get.
Mhm.
And I think that especially in medicine, our the way we're structured and the hierarchies we have, that those student voices are often are just often quelled. And I just think that it's a shame. Like, there's just I've students have really inspired and transformed the way I think, and as my kids have. And so I just yeah, I think that my young collaborators are definitely you know hold a spot in my heart for sure.
It's interesting because you've done what might be a couple of head fakes in that one, because on the one hand, as you were saying, my household might not appear like a democracy, and then I was thinking that what will follow is that you will be some sort of tyrant, but it's actually
Mhm.
your kids running you. So
Yeah, no, they
that
do.
was that was
Yeah,
the
they do.
first head fake. And then the second one is that you're finding your best collaborations in people that perhaps, if I were to ask them, they will be describing themselves as looking up to you, or learning from you, admiring you, and so forth. They may not see you as a collaborator, but you pretty much see them as teaching you and helping you be better. Did I get that right?
Oh, absolutely. And I think that and my patients as well, and I shouldn't say my patients, they're not, I try not to use possessive language, because but the patients that I work with, um similarly, I think that I have learned so much. And there's and again, this is the generosity, right? Is that all patients that come and are trust you, and are comfortable enough with you to lay out some pretty personal and intimate stuff. I mean, that's extraordinarily generous.
Mm.
And then and again, I think that I've been struck by how that generosity has truly been transformative in how I think and how I do things.
When you think about thinking now about your academic work,
Hmm.
as a physician, as a researcher, as an academic leader, what do you think is the meaning of the work that you're doing?
Um, well, what I hope, I think if it's sorry, just like, I'm going to tangent a little bit, but I promise I'll come back. But I think again, sort of thinking about sort of this mid or early to mid career experience, or sort of that transition from early career to mid career, where again, you're sort of, you've had an early career investigator award, and you're sort of validated that, okay, you've got some good ideas, kid, let's see what you can do. And then in that mid career where you're trying to really establish yourself, and you've often finished a first program of work and you're trying to figure out how to reinvent yourself, and this is when more awards and things like that become really important in terms of kind of giving you opportunities. At that time I struggled a little bit, and I still I think again with medicine, we are pleasers. We are looking to make sure that we're doing the right thing, and we've set up a system where we're quite dependent on those external, those regular boluses of external validation. And I was struck that year after year, I was, again, the sort of my confidence in myself and my joy in work was being eroded, knowing that I was needing those things. And I think I've gotten to a place in my career, and partly it was, I think just sort of just serendipitous connection with a couple of, of really important mentors, that, just sort of made me really challenge, like, the why, like, why are those things important? And really at the end of the day, like, what is it that I want to do, and what is it that is most meaningful, and do I need those things to tell me that those things are good? And I think that I'm very grateful to to those people, that have made me see that. I think that if I were to say what do I want my work to accomplish, what's the meaning of my work, is actually I'd like to be someone who nudges major culture shift. And I'd like to, kind of think that some of the work that we're doing right now might really challenge how we're thinking about how things are structured, and how our structures are actually contributing to a lot of harm. And I think harm for patients in terms of, again, we've got these hierarchies that are very oppressive, um, that continue to harm patients, that continue to erode relationships between patients and clinicians. I think that within academia, we have an educational system. The medical education system in particular is also quite oppressive, and not equally so. It's generally oppressive, but particularly oppressive, to racialized learners. And so I think, it's just sort of I hope that the lens of equity that I bring to the work that I do, and my genuine commitment to equity, um, will will start to, again, sort of start some of these more challenging discussions about, do we really want to continue this? Do we really, do we really want to continue engaging in preventable harm when we can be so much better?
Mhm. Mhm. So, to help us understand what you mean by oppression.
Um, well, I think, when I use the word, I, I use it as a, I think that I basically want to communicate that there are times when people are really left without freedom or choice.
Hmm.
And there is, I think it's a combination of, there's a there's a removal of choice, there's a removal of autonomy, um, and there's, a um, I think that the people who are experiencing oppression often feel that there's just there's a lack of control in those situations, and unfortunately with that, a lack of hope. So I think it's a combination of all of those things. I think it's a withdrawal of hope. It's a withdrawal of dignity, and it's a sense that there's little choice and little option for them, and the only path forward is the path that, someone who they perceive has control over them is telling them to take. And
So,
I think that, No, sorry, go ahead.
Yeah, no, so it's just drawing a parallel, so you go into healthcare as a patient, you get care, and you've described ways in which care can be cruel to people when it, for instance, fails to capture, understand what's going on, or where it throws, in addition to care, it throws stigma into the picture, as you discuss the that shift between, oh, you must be very sick, maybe you have uncontrolled diabetes, or oh, it's mental
Hmm.
illness. Oh, okay, that's a different story, right? So that
Hmm.
shift, that's cruel. And but now you describe in education a parallel syndrome, in the sense that, or a parallel phenomenon, in the sense that Amartya Sen and Martha Nussbaum, for instance, talked about people having capacity, and what society, a just society, what it does is it looks to remove all the barriers for people to flourish and manifest that capacity, and manifest their potential. And I'm thinking of Malala Yousafzai, so being being shot because she wanted to go to school and learn, and the patriarchy where she was growing up, would not tolerate a girl having those types of ambitions. How? But that seems very extreme, getting shot in the face because you want to learn. That seems a very extreme, very in your face form of oppression. How does it manifest in medical education, you think? Because again, you go there trying to flourish, and then you're telling me, no, 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 there is a mechanism of oppression that is preventing that exact thing from happening. How give me an example how that ends up happening?
Well, I think in medicine, it's what's most sinister about how it happens in medicine is extremely it's invisible. Like you actually have to really look for it. And I think in terms of there's more, and there's been quite a bit discussed thanks to sort of the work of several leaders in this area. Esther Chu and Argo Gonzalez. Like there's a number of very, very notable women that have been out there talking about sort of the gender gap in pay and gender gap in opportunity. And we see it in we see it in academia. But we even see it in clinical outcomes. And I spent, I started my career looking at gender differences and sex differences in cardiovascular care in women with diabetes, or men and women with diabetes. But we see this, we see these subtle biases play out in terms of um, you know like the women's like how women are engaged in terms of clinical decision making, how women are perceived when they present with symptoms. um, there's again these biases that just continue to play out. And I think as clinicians that are trained in science, we believe that we're not prone to making those systematic errors. And so that's the tricky thing, is that we've convinced ourselves that we are not creatures of bias, that we are creatures of science. And it's a fascinating thing that when you start revealing these systematic errors, that nearly half of all women that present with ischemic heart disease aren't recognized as having ischemic heart disease at the first presentation. They're dismissed as something else. When you look at the sort of the representation of Black, Indigenous, or students of color in medical school, it's significantly lower than it is in the population. We make systematic errors. We just aren't very good at recognizing them or acknowledging them. And then this plays out throughout people's education, out through their careers, and it plays out, for several patients as they interact with the healthcare system. There's an experience of, these all these interactions with the healthcare system that leave them feeling disbelieved, or leave them feeling invalidated. That adds up, and it leads to very well-earned distrust of the medical system. And I think for students and that have experienced those experience, which may be overt, um, you know, aggressive acts of interpersonal sexism or racism, or they may be maybe very subtle exclusions and omissions. But over several years and over decades, it leads to quite significant trauma and quite significant hurt, and as you mentioned, like just a tragic loss of opportunity, that ultimately is something we all suffer from.
That's
There's a
amazing.
I think yeah.
It's a so this series is about care that fits, and the efforts that clinicians in the office make with patients when they work together to try to craft programs of care that make intellectual, emotional, and practical sense to people, and of course, the work people that then have to do at home or in their life to try to make that care program, fit with all the
Mhm.
other demands and routines of their life. Um, how does this lens that you bring work to make care fit better?
Well, I think I just submitted we just submitted a grant on situational literacy, and situational literacy is this construct that we kind of as our team kind of developed, and it's this idea that it's um it's the recognition that every person is going to come to the table with a certain degree of medical complexity and a certain degree of life complexity, and situational literacy is that understanding of how those two things interact in this person. And we wanted to use the term literacy because it's not just a competency, it's not just a set of skills, it's this enhanced understanding, it's this ability to communicate, to truly understand, to be fluent in the lived experience, essentially. And I think that since submitting the grant and sort of thinking about sort of the your book and the language that we use in the patient revolution, it's really a different way of approaching sort of seeing someone in high definition. And I think that we when we were sort of trying to come up with this construct of situational literacy and thinking about situational literacy and the importance of it in shared decision making, I was left with again this idea that when you have a clinician patient duo, and I'm not going to say they're partners yet because I think that partnership is something that's earned. It's not something that's a given. And the way we develop that partnership is trying to close the gap that naturally will exist between a patient and a clinician. Again, our structures bring these two people together in a way that's not entirely voluntary. Um, a patient is assigned through some sort of central access and triage process. There's no, and at least in Canada, that's how it happens. And then patients, are there, not because they necessarily, often because they don't want to be there. They have a diagnosis. They have pain. They have unwanted disability. They have, unwanted symptoms. And so they're sitting there with this imposed state, and physicians come in with a very chosen state, in my case chosen at age 10. And so it's a very 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 unequal playing field. And I think that I think our hypothesis is that if it physicians, clinicians, you know it's to make that environment more comfortable, more safe for shared decision making, to ensure that the trust is there so that that process will go well. Because again, physicians often think we're doing something that we do all the time. We think we're really good at shared decision making, but the data would suggest we don't do it very often, and we don't necessarily do it fairly well. We don't necessarily do it really well.
Mm.
Um, and I think again because um, we're sort of caught up in the process, and we're caught up in the method, and we sort of kind of forget that a key part of shared decision making is really 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 understanding the experience of the person in front of you, and getting them comfortable, and getting them to trust. And I think that the way that patients trust, especially patients who've experienced trauma, who've had adverse experiences in the past, is for you to take that time, to take that effort to become fluent in their lived experience.
So,
And the physician needs to be the learner in that scenario to get to that point of partnership.
So you've in this discussion you've taken us through two kinds of challenges, I think, in seeing the patient in high definition. Initially, I think the challenge of stigmatized conditions, conditions that perhaps are not fully understood, um, that really strain the ability of whoever is called to care professionally, a clinician or a friend or family that comes to the side of the sufferer. There's the ability to act with compassion towards someone that's going through something that you perhaps have difficulty fully understanding or capturing, and that's almost on the biological side. And then you're bringing up an additional level of complexity, which is fully understanding the biographical and historical
Hmm.
challenges that a person is going through. um, Caring for people is hard if one has to do all these things, right?
It is. It's really rewarding, though. I think with anything, like it's just it's the it becomes and I've um I think the concept of love has been discussed a lot in this carecast, and I think that you know love doesn't come easy. You've got to, you do have to work at it, and relationships take work and take time and take dedication. um and so I think yeah, I think that and this is again where we have to look at our structures. We don't value that um currently in how we've structured care. There's, it becomes too easy to not take the time.
Check the box, do the guideline. So
Exactly.
a student that's trying to get that's trying to be like you and work well in healthcare, finds those structures. You describe them as oppressive, restrictive, limiting, channeling. Perhaps you know where
Mhm.
you stay on your lane, so to speak. Is your advice to a student to stay in your lane and conform and get it through, and once you get to my level then you speak out, or do you set them out for to fail, so to speak, because they become the troublemaker and the person that is this uncomfortable and trying to raise the issues you're raising, but at the point where they have, as you pointed out before, nobody's listening to their voice, they have no power, and they're desperately trying to fit in. So what should a young person to do in that sort of situation?
Yeah, I mean, I think that I've like this is something I actually think a lot about, because I think that particularly um you know one of the things when you're doing a lot, when you spend a lot of time in the equity, diversity, and inclusive space, and you're trying to figure out how can we, how do we 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 desperately need to be a more diverse clinician community. Um, there's so much evidence from the corporate world in particular that the more inclusive we are in terms of, just having good representation from, from, from the, from the disabled community, from LGBTQ2 plus community, from racialized communities, like the more representation we have, the more diversity of life experience we have, the more views we have, the the better we are. We just are, we just think more creatively, we think more compassionately, we problem solve in such a better way. It is there's just so many reasons to be inclusive, beyond just that it's morally important to be inclusive. um, but I think the thing is that when you have these existing structures that we know are harmful, you have to, you want to, we feel this urgency to 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 be as inclusive and diverse as possible, but we have to make sure we're doing the work on the other side to ensure that we're actively knocking down those things that are going to hurt people. If we, we don't have a, we right now our systems and our structures, um, are oppressive, they are hurtful, and we need to be actively knocking those things down and challenging those things to ensure that we don't hurt this diverse community that we're trying to grow. And so along those lines is again sort of how do we coach students, and what's our responsibility to keep those students safe, and give them an environment where they can thrive.
Do
And I
you
think that's really tricky.
recommend your colleagues and other teachers that are in contact with those students uh, to foster that those challenges, or how do you create an environment for students to be able to kind of open up their wings and show us a different trajectory than the one that we've set up for them?
Well, I'm hopeful at this point that we've got there's like I think that yeah, I don't know. I you know, I mean, I'm very fortunate right now that I'm in a position where I like I have a leadership position within my, within my medical school, so I can start, sort of busting some things up and work with students to rebuild them in a way that's far better and healthier. Um, I mean, I have leadership in a compartment in a bigger, in a bigger organization. So sort of busting through all of those other walls is something that's a work in progress. I mean, I am very grateful to be at the University of Calgary right now because I do think we have leadership at a variety of levels that's really quite open to some serious demolition and reconstruction, that's inclusive and healthy and loving. Um, so yeah, so it's an exciting time, and I think I mentioned because I think I recently was given a new position where I've a little bit more a few more opportunities to bust some things up and do some things differently, and was a little surprised that I was offered the position, but at the same time really heartened that people know what I like to do, and as sort of going back to the very beginning of the discussion, sort of I've been fortunate enough to be able to get the opportunity to do it. So yeah, I think that there needs to be a commitment from leadership, to restructuring things, and I think it's very 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 difficult to make those changes unless you've got sort of leaders that are willing to say, okay, like we don't really, we're a little uncertain of what the next phase will look like, but we trust that you know you'll take us in the right direction. um and I have to say, like, it's just like it's something that still continues to move me, that I might be someone who can help with
Well,
that shift towards something that's healthier.
if they say that the arch of history bends towards justice, it's probably because of people like you that's pulling it down. So you're pulling it in that direction. Doreen, it's been a wonderful gift to have you in the CareCast and to see your clarity and your courage and your your commitment to students, commitment to young people, and to create a better world. And it's been a pleasure to have you with us. Thank you for joining us.
Well, thank you so much for having me.
Excellent. And thanks everyone else for joining us. Please join us for our next CareCast brought to you by the Care Unit. And please take care.